start with the case presentation. This case presentation will be done by one of the ID registrars, Dr. Mbolo Wadia, and then we'll have a didactic presentation that will come from Professor Achamba. So we advise you all to be present and actively participate. So at this point, I'll allow Dr. Mbolo Wadia to go ahead with the case presentation.
Good afternoon, everyone. You're all welcome to today's eco session as we talk about severe bacteremia in HIV. So I'm presenting male 52 MC, who's a long-stay hospital patient admitted on the 23rd November up to date with multiple comorbidity conditions, RVD era since 2021 on TOD plus DTG, non-diabetic with poor compliance, and the CD4 is at 60, viral load is at 70,848. So has TB co-infection with findings of lung positive mirrorly picture on chest X-ray, and he has been on ATT for 3 months. He's a non-diabetic since 2008 with poor glycemic control, and is hypertensive since also 2008. Also currently has a resolving AKI renal dysfunction, and currently has hiccups. His old stroke, right MCA in November 2023 with fourth ventricle mass, a new left MCA syndrome, also which occurred in January 2023. Also with complications of aspiration pneumonia and persistent encephalopathy. Also concerns of non-convulsive status. So he's recently treated for SARS-CoV-2 pneumonia in January. After persistent respiratory symptoms, the patient was swabbed and the RDT was positive. Now has a new onset dry gangrene of the left bilateral lower limb with pressure ulcers, and keep it as ulcers as of February. There's also upper GI bleeding, likely secondary to peptic ulcer disease, and has a background history of alcohol, and was a chronic smoker. The current complaints are through colorectal history from the wife. There's hiccups, episodes of profuse sweating, fever, wet cough, vomiting blood, melena, ascending dry gangrene of bilateral lower limb. So on examination, the patient is opening eyes spontaneously, but easily falling asleep, no localizing to stenorrhea, and not withdrawing from nail bed pressure. It was mute, diaphoretic, with oral thrush, no knuckle rigidity. The Koenig sign was negative, and the Brzezinski sign was negative. Also has tetraparesis. On the chest examination, he had transmitted breath sounds with occasional crepes, respiratory rate of 29 breaths per minute, saturations of 95% in room air. On saturations of 95% on nasal prongs at 6 liters per minute of oxygen. On the cardiac exam, his S1/ST was regular, but tachycardia with a heart rate of 31 beats per minute and a blood pressure of 135/78. The abdomen, so soft, no obvious tenderness, no organomegaly, and the bowel sounds were present. In the musculoskeletal, he has ascending dry gangrene of bilateral toes with absent dorsalis pedis, not palpable. However, the popliteal and femoral pulses were palpable and had decubitus ulcers with slough. The RBS was at 17.4 millimoles per liter, and the temperature was 37.7 with spikes on the TPR chart. So on the assessment, this is a MC male 52, long hospital stay with advanced HIV disease on TOD and DTG with CD4 of 60, viral load of 70,000, with disseminated TB co-infection on ATT for 3 months, a non-diabetic hypertensive with a bihemispheric stroke, persistent encephalopathy with concerns for NACSE, resolving aspiration pneumonia, VTE with dry gangrene of the lower limbs with pressure ulcers less than 2 months post-COVID. Also with PUD, complicated with upper GI bleed, the background history of alcohol, chronic smoker with septicemia. So these were the lab results for the patients that we've had from the time of admission up to date. So on the full blood count, it has been in the range initially of 14, then it was 13.1 in February, and the latest one is at 6.1. The creatinine was at 9.4, then later 102, and now at 71. The urea was at 63. Then, sorry, not 63, but it was 6.3, then 10.6, and now at 10.1. The blood culture, initially it had no growth, and as of January, nothing was done. Then when we started seeing the patient in February, the blood culture showed a coagulase negative staphylococcus. And the latest one that was done this week is still pending. The white blood cell count initially was 10, then it went to 28.2, and now at 20.1, with predominant neutrophils. And CRP was initially at 365, and now it's at 154. RPR was done in November last year. At time of admission, then it was negative. The serum CAG, toxo IgG and IgM were also negative. The HbA1c for the glucose control in January, it was at 11%, and the latest one is now at 7.1. However, this one has a compounding factor of the low HB, so it's not reflecting a true picture for the patient. And of the electrolytes, we had 4.7, nice calcium at 1.07 and 1.5, the chloride at 103, and December, the normal, and the LFTs have been also in the normal range. Chest X-ray showed a merely picture. The CT brain showed the right thalamic infarct with a fourth ventricular mass. And as I mentioned earlier, the COVID was a surface antigen RDT positive. Yeah, this one is just to basically showing us the ART that he has been on since 2021. Initially, he was on TOD before, and then now he's on the TOD with the DTG since he started the ATT treatment. And the CD4 is at 60 with a viral load of 70,848. So currently, the patient has been on different antibiotic treatment, which has been ceftriaxone, which the patient has received for a month plus, cefotaxime for greater than 2-3 weeks, and then has been on Septrin since admission. He received metronidazole the time he had aspiration pneumonitis. That was for he was given for 2 weeks, and also has been on the ATT. Then of note, the old drug charts for the patient have not been kept well. Therefore, we're not able to really determine the actual duration of these antibiotics that the patient has received since admission. The other drugs the patient has been on is paracetamol, actrapid and protafen, vitamin B6, dexamethasone, metoclopramide, omeprazole, TOD, DTG, levetiracetam, and also received remdesivir during the time he had COVID. So currently the patient is being managed as a multidisciplinary approach under ID, endocrine, neurologist, physiotherapist, nutritionist, and the surgeons. So our questions are, is the current worsening of the condition due to the coagulase negative staphylococcus, and how would we approach the treatment of this bacterial infection? That is the approach of suspected bloodstream infection, our topic for today. Thank you.
Thank you so much, Dr. Mbolo, for that nice presentation. So we've seen this case, and we've seen how extensive and in terms of multiple comorbid condition that the patient is having at the moment. And then we get to see that when some blood cultures were sent, they isolated the coagulase negative stuff. And then from there, we're seeing that this is a patient who is also having a condition that's worsening in the state of immunocompromised. CD4 last check was 60 with a viral load of above 70,000. And then we get to see that the patient is also developing dry gangrene, which is also extending. And then later on, they isolate the cones. So the question is the current worsening of condition due to the coagulase negative staphylococcus? And then want to understand how we approach the treatment of this bacterial infection. In particular, we want to look at the approach of suspected bacterial stream infections in HIV-infected patients. Thank you so much, Dr. Mbolo, for that. And at this moment, I think we'll stop sharing the case presentation so that we allow the IT team to share the actual presentation for Dr. Achambwa. We are glad to have you on the platform, Professor Achambwa.
Thank you. I'm wondering actually if, so my presentation is not very long because in our guidelines, the Zambian guidelines on advanced HIV, there isn't a very big section on bacterial infections, and I wanted to keep myself as close as possible to the guidelines. But I'm just wondering if this case is very, very complicated, and I know it was presented in a sort of very quick way. If there are additional clarifications that people wanted to ask about the facts of the case and make comments before we go to my presentation. So maybe if you don't mind, we could go back to that presentation and just have clarifications, people ask questions and make it very clear. Because there were some slides which were very dense, and it's possible that not everyone got everything that was presented on what the patient has and any additional clarifications. Is that okay, Dr. Mao?
Yeah, sure, Prof. We will take that direction.
Yeah, so maybe using either the second slide or the ones which have results, we can open it up just to get clarification or additional questions, just to make sure everyone is.
Okay, the audience, I think I've seen a hand, so we'll start with the first hand. Okay, we have two hands now, so I'll allow the first hand to go first. That's Dr. Webster. You may go ahead with the question.
Okay, thank you very, very much, Doc. And good morning, Dr. Mbolo.
Morning, thank you.
So this was a very complicated, like what Professor Achambwa said, the case has a lot of issues. But my only concern was on the diagnosis of TB. I know you mentioned urine lung. You also mentioned that the X-ray wasn't very good, but I don't know if you tried to do also the gene expert. If you didn't, why you didn't do? Because obviously we want to know the resistance pattern. Looking at this patient who's severely ill and has advanced HIV, and we know that those that have advanced HIV, they're predisposed to having drug resistance. And if we didn't do, did we also consider doing maybe, if they are not producing sputum, did we consider doing to the gene expert. I submit.
Thank you, Dr. Chewe. Yes, sorry, I think it was just a mistake when the slides got edited. Yes, the gene expert was done, both sputum and stool, they were negative.
Okay, so the gene expert was done. And now we get to see that the result is as communicated. But then looking at the CD4 of 60, and of course, someone that gives a positive urine lab with this clinical presentation. So a decision was made to go ahead with the treatment of tuberculosis, as disseminated tuberculosis. It's giving us a mirrored picture. So we'll get the other question from Dr. Zambo. Albert.
Good afternoon. An interesting case. I just wanted to seek some clarity on a few points. You mentioned that at some point the patient got a positive blood culture with coagulase negative Staphylococcus aureus. So on that, I wanted to first find out, perhaps I could have missed it, first the timing of it, like when was it first diagnosed? And then was there a follow-up blood culture to confirm that this was not mere contamination, but rather actual Staphylococcus bacteremia? Then on the drug regimen, I noticed that, sorry, on the same Staphylococcus aureus, I don't know if a sensitivity was provided from the lab, and what type of sensitivity did this coagulase negative Staphylococcus aureus yield to direct our treatment? Because like you say, this is a patient who's been on a beta-lactam ceftriaxone for more than a month without improvement. And then also, just on this, the coagulase negative Staphylococcus, did they check for the possibility? Was it written Staphylococcus negative coagulase bacteria on the report, or they just said gram-positive diplococci? Because some labs sometimes just send on that before characterizing the bacteria. And in someone who is DM, we might want to be on the lookout for the possibility of disseminated candidiasis, especially in this patient who has poor glycemic control. Then on the drug regimen, as my last question, I noticed fluconazole is not there, given the patient's CD4 count, either as prophylactic against Cryptococcus or not. So is there a reason why the patient was not started on prophylactic fluconazole in this case? Thank you.
Thank you, Dr. Zambo, for your questions. So concerning the culture, yes, this was a result, as it is as a coagulase negative Staphylococcus. And however, our lab did not send back to us the resistance and stable pattern with it. So however, we went on to repeat a blood culture again, which is still pending. The results haven't yet come back. And there was a hiccup in repeating it because currently we don't have culture bottles, and the relatives were not able to afford at some point. So there's one which we're expecting to have results by the end of this week. And then the other question concerning the fluconazole. Yeah, I think it's a good observation. Thank you. Likely on from the file review, and there's a point it was mentioned, but I didn't have the evidence because the file from last year, it has been misplaced. And now currently, due to the long hospital stay, we have a smaller file that the patient is having now. So most of the drugs that you received last year are not able to be identified.
Now, thank you so much for those questions. Very important observations, especially seeing that the cones were isolated and we needed more information on what was isolated. Quite right, the follow-ups have been done, and the other challenge is that the antibiotics in the lab to do the susceptibility testing is not available as well. So we are hoping with a new specimen that was submitted on Monday, they assured that they'll try by all means to give a comprehensive report so that we get to see exactly, are we isolating the cones? Is it just contamination, or what are we dealing with in this particular individual? Yeah, thank you for those observations. Do you have any other questions from the audience? In the chat box, there are no questions. I can see Nalolo DHO, they were asking for the link. IT can assist with that. Or if we have any comments from Professor Chambwa.
You can discuss. The other experts are here. I see Dr. Chitalu Chanda, and I'm not sure if Dr. Duncan Chanda has joined as well. But so I could probably do my talk now, and then we'll come back to this case. I just wanted to allow for time for people to get clarification. Like I said, that's a complicated case, so it needs a bit of dissection to make sure that everyone follows it very well. But it's a very good learning case. It's sort of the kind of case you need a lot of help. So we can go ahead, if you can share my presentation.
IT, you may go ahead and do the projection.
Okay, thank you very much. So we'll discuss severe bacterial infections. This is a very broad topic. I hope everyone can see the slides. And maybe we could just put them in presentation mode. Okay, so this is a brief outline of the talk. I'll look at who is at risk for severe bacterial infections in HIV, and then we'll touch briefly on some of the conditions, because the treatment is condition specific. And then because a number of bacterial infections can lead to sepsis, we'll also touch a bit on the management of sepsis. So you can go ahead to next slide. So in terms of who gets severe bacterial infections among individuals who have HIV, maybe I can just start by giving the background, which you're all very familiar with, why people with HIV infection get bacterial infections. And this is mainly from defects in the immune system. So the CD4 count, a reduction in the CD4 count is a hallmark of HIV infection, especially advanced HIV disease. When someone has had HIV infection for a long time, for many years, the CD4 count gradually drops until it drops below 200, at which point they're at increased risk for severe infections, including bacterial infections. So that's a cell-mediated immunity, part of the immune system, that gets affected, and we see that by a decrease in the CD4 count. The other conditions which lead to a decrease in the reduction in the function of the cell-mediated immunity, such as steroids, some of the drugs that are given for cancer, and other conditions. But HIV infection also affects the humoral immunity, so the function of the B cells. So CD4 cells are important in the function of the B cells. In addition to that, there's also activation of the immune system, so that there's increased production of non-specific immunoglobulins, and then also the function of the neutrophils, and the number of neutrophils themselves may be reduced. So that also increase the risk for bacterial infections. Without treatment, especially before there was ART widely available, you'd notice that a number of people have a low white cell count, low platelet count, and a low HB count as part of the picture that someone has with a HIV infection. So that decrease in the neutrophil count and sometimes the function of the neutrophil count contributes along with cell-mediated immune dysfunction and humoral immunity dysfunction. Then for patients with HIV, there can also be defects in the barriers that prevent infection. So natural barriers to infection would be the intact skin and the intact mucous membrane. So there'll be disruption to those. So from chronic diarrhea, there can be disruption in the integrity of the gut mucosa, so it can be translocation of bacteria there. And also when there's, especially in acute, jumping to acute HIV infection, when there's a rapid decline in the number of CD4 counts, because a lot of the CD4 counts in the cells are in the gut-associated lymphoid tissue, the gout, the Peyer's patches. So when there's a decline in those CD4 counts, there can be a disruption in the integrity of the mucosa. And so there can be translocation of the bacteria, which leads on to inflammation, the chronic inflammation that you have in HIV infection, which affects many other things, including risks for cardiovascular disease and other non-AIDS defining conditions, malignancies, and all those things. So all that can be from disruption, but also infection can go in the skin. And then if you can go back to the previous slide, sorry. Yeah, and then there are also procedures when patients are admitted. There are procedures that are done which breach the, which are invasive and can lead to risk for infections. And then because of the frequent contact with the healthcare system, sometimes antibiotics are prescribed, which increase the risk for resistant organisms. And so because of that, you can have infections. Just to pick pneumonia as an example, the risk factors for severe bacterial pneumonia, and these are from old studies way back in the 90s. There were cohorts of individuals that were followed up just to see those that had HIV infection and those that didn't have HIV infections to see what the main risk factors were for developing of bacterial pneumonia. So they followed individuals for episodes of pneumonia over a period of time and found that CD4 count was a major factor in the development of pneumonia. So with severe decline in CD4 count below 200 being, let me just give some of the data. So the incidence of bacterial pneumonia for individuals with CD4 count less than 200 was 10.8 per 100 person years, whereas in those with individuals between 200 and 500 CD4 count, the incidence of pneumonia in the HIV positive was 6.5 episodes per 100 person years. And then those above 500, it was 2.3. And so you can see that the higher the CD4 count, you still get pneumonia, but not as frequently as those with low CD4 count. And the other risk factors for pneumonia, which we'll talk about as we discuss pneumonia. Next slide. Okay, so what are the, yes, that slide. So what are the common bacterial infections among HIV infected individuals? So in general, I sort of classify them into three groups. So there are bacterial enteric infections. Then there's pneumonias, and then there's bacteremias. So let me just talk about bacterial enteric infections. So these are gastrointestinal infections. So for these, the main infections are caused by Salmonella. So Salmonella, most of you are familiar with typhoid or Salmonella, the one which causes typhoid. but there's also non-typhoid or salmonella, which in immunocompetent individuals is not a big issue. If someone has diarrhea and their stool culture grows salmonella, non-typhoid or salmonella, it doesn't cause much of a problem. But in immunocompromised individuals, those who have HIV infection, it can cause problems. So salmonella is a big issue. And then you also have Shigella, different species of Shigella. And those are also an important cause of enteric infections, infections of the gastrointestinal system. And then you also have Campylobacter. Then you also have what used to be called Clostridium difficile infection. The new name is Clostridioides difficile associated infection, or CDI. So this is common in individuals who've received antibiotics. And then for individuals with HIV and the CD4 count less than 50, the risk is higher. So the Salmonella, as I mentioned, that it's the non-typhoidal Salmonella, even the Salmonella enterica, serotype Typhimurium, and also Enteritidis. So those can cause infection in the individuals. And the presentation for these bacterial infections that affect the GI system can range from a self-limited gastroenteritis, so just diarrhea, which is self-limited. It can also, the second presentation would be a prolonged diarrhea disease. And sometimes this may be accompanied by fever. There may be bloody diarrhea. There may be weight loss. So for Shigella and Campylobacter, in individuals who have HIV infection, you can have that more severe disease, which is bloody diarrhea, and the duration is much longer. And occasionally, you can actually get bacteremia in individuals who have bacterial infections of the GI tract. So diarrhea is defined as 6 or more loose stools. So the loose stools, if they take the shape of the container, that's defined as a loose stool. And they can range from mild to very severe disease. In terms of diagnosis, there should be a complete history, including a history of food that's been ingested, water, whether it's clean water or not. A sexual history is also important in trying to determine the cause of diarrhea, or assessing an individual with diarrhea. And exposure to certain pets. People keep all kinds of pets. And salmonella infections particularly are common in individuals who may have some reptiles as pets, such as turtles. So those are associated with salmonella infection, or snakes. If someone keeps snakes as a pet, those are some of the things that you'd want to get history of. A history of medications is also very important because, as I mentioned, that for Clostridioides difficile associated infections, antibiotic exposure is important. In the history, you also want to get information about the stool frequency, the volume, the duration, the presence of blood, and other associated symptoms such as duration of fever, and then examination to assess if there's dehydration, assess the volume status of all those infections. And then for culture, it helps in identifying the organism. And again, it's better to do the culture early on in the admission. When someone, if this is an inpatient, when someone just comes in within the first day or two of admission, you want to do a culture. And if it's possible, there are molecular techniques that can be used for testing for some of these infections, like the CDI that I talked about. But in general, stool culture will be helpful. And you're likely to grow some of these Salmonella, Shigella, Campylobacter. And let me just talk about the treatment before I move to the next slide, because I don't have that elsewhere. So those are the common infections. So preventing of exposure for people who have HIV infection, especially with low CD4 count, the most common cause, as I mentioned, is food and water and fecal oral exposure. So you want to educate individuals about these ways in which someone can get HIV infection. The fecal oral exposure sometimes can occur because of certain sexual practices. So you want to give advice again of things that would increase the risk for diarrheal diseases. That's on prevention. And then you obtain stool culture as part of the diagnostic workup. And then for some, you could do either PCR or other molecular techniques that can be done for those conditions. And once you get the results, it would help in deciding specific pathogen-specific therapy. So for Salmonella, quinolones are a good choice. And again, one ought to be familiar with the local susceptibility patterns. So each hospital will have different susceptibilities to different bacteria. So you'd want to be familiar. So quinolones would be effective in treating salmonellosis. And this can often lead to bacteremia in patients who have HIV infection. And then Shigella and Campylobacter can also be treated with fluoroquinolones, and beta-lactams can also be used in the treatment. And again, the duration will vary depending on the type of infection you have. We can move on to the next conditions. So that's what I had on enteric infections. And then the other common one is bacterial pneumonia. So bacterial pneumonia, again, is an important cause of infection. In fact, let me say respiratory infections are a common cause of common opportunistic infection in individuals who have HIV infection. It can occur with any CD4 count. The higher the CD4 count, then the presentation would be similar to the HIV uninfected individuals. And then for the lower CD4 count, you may get more severe. So a main risk factor, as I mentioned earlier, is the low CD4 count. If the cause is Streptococcus pneumoniae, which is one of the encapsulated bacteria, the B cell function abnormalities, neutrophil function, and their numbers will also be a contributing factor to the development of bacterial pneumonia. They can also be because of alveolar macrophage dysfunction. Then for pneumonia, just like the general population, there are other common risk factors such as congestive heart failure, chronic obstructive pulmonary disease, COPD, cancers, lung cancer that can cause a post-obstruction pneumonia, renal insufficiency. All those are risk factors for pneumonia. Tobacco use or cigarette smoking, injection drug use is also a risk factor for pneumonia. And then older age, individuals who are older, who have HIV infection, that can also be a risk factor for pneumonia. The common organisms that cause pneumonia, bacterial pneumonia, are Streptococcus pneumoniae and Haemophilus species. So those are traditionally the common causes of pneumonia. Didn't include in here some of the studies, and you can look them up, that especially in children, which have shown that with the introduction of pneumococcal vaccine, they've seen a change in the pattern of the organisms that are causing pneumonia. So you can look those up, even in Zambia at Children's Hospital. There have been a number of studies that have been done that show the change in the organisms that cause pneumonia after introduction of vaccines in children. And these may spill over even to what causes pneumonia in adults. In Zambia, we do not have pneumococcal vaccine available, unfortunately, for adults living with HIV infection. But ideally, that should be one of the vaccines that we give to our HIV-infected population to reduce the risk of pneumonia. Hopefully in future, as we go on with the lifelong approach, the life course approach to vaccines, where vaccines are not just for children, but also for adults. COVID vaccine is one example. The other vaccines that adults need, and pneumococcal vaccine is one of those which would be helpful for individuals who have HIV infections. So hopefully we'll have such a vaccine for our HIV-infected population in future. Other organisms are Legionella pneumophila, which is an atypical cause of pneumonia. Mycoplasma pneumoniae is also another atypical cause of pneumonia. Chlamydophila species, different species, another atypical cause of pneumonia. And then Staphylococcus aureus, which can either be methicillin sensitive, in which case you can use beta-lactams to treat it, or it can be methicillin resistant, which is MRSA. The abbreviation that's shown there, in which case beta-lactams, especially the older beta-lactams, may not be very useful. And then Pseudomonas aeruginosa, which can cause a very severe pneumonia. And then Rhodococcus equi is another infection that can cause pneumonia in individuals with HIV infection. I should have included nocardia is another cause of pneumonia in individuals who have HIV infection. There are several other causes of pneumonia, but I just listed those as the common ones that we should keep in mind. Next slide. So in terms of diagnosis, a chest X-ray is very important for all patients who are suspected to have pneumonia. The findings of the chest X-ray will vary depending on the CD4 count, depending on the organism that you have. If it's a classic pneumonia with a Streptococcus pneumoniae, whose history is just 2 to 3 days, a pleuritic chest pain, high fever, white cell count, and the physical exam findings that are consistent with pneumonia, such as agophony, bronchial breath sounds, and all those, a chest X-ray might show a focal consolidation. And sometimes if they delay in presenting, there might be a parapneumonic effusion. So that would be the findings on chest X-ray. If it's Legionella pneumonia, it might be a different picture. If it's Mycoplasma pneumonia, it might be a different picture where it's both lung fields involved. And then, of course, we'd keep in mind the other causes of respiratory infections in HIV-infected individuals that are not the focus of our talk today, such as pneumocystis jirovecii pneumonia. So that would be another big differential for people who have a respiratory infection and have HIV infection. And then COVID is another one that you would want to keep in mind. Then, of course, in this environment, Mycobacterium tuberculosis should always be suspected in anyone who presents with a respiratory infection, pneumonia, and has HIV infection. So investigations in addition to chest X-ray would include evaluating for TB with GeneXpert and AFB smear and AFB culture. So all those patients with advanced HIV disease should have evaluation for TB, in addition to the urine lamp, which is in the Zambian guidelines for advanced HIV disease. Then blood cultures will also be useful. And if available, there are rapid tests that can be done for patients with pneumonia. Urine tests that can be done for Legionella species, Legionella pneumophila, and also streptococcal pneumonia infection. So those are also very helpful. You'll get results very quickly for pneumonia. Next slide. And then we also have bacteremia in advanced HIV disease. So this can be from all sources. I talked earlier about non-typhoidal salmonella with the risk factors that we talked about earlier. Streptococcus pneumoniae is another cause of bacteremia, E. coli bacteremia, Staphylococcus bacteremia, which can be either methicillin sensitive or methicillin resistant. And then coagulase negative staph is also another infection. You cited one study here a few years ago. Dr. Mchemwa and Dr. Andrews did studies. They were looking at causes of bacteremia in patients with HIV infection, and they found that overall, at least at that time at UTH, the major causes of bacteremia in HIV-infected patients were mycobacterial infections. So basically TB was a cause of bacteremia. Now, obviously, with TPT, with prevention therapy for TB, the incidence of TB in HIV-infected individuals is reducing. So the picture may be different now, but maybe 8 to 10 years ago, this would have been the picture where mycobacterial infections are a common cause of bacteremia. And again, different hospitals will probably have different pictures. And common sources would include the urinary tract, the abdominal cavity, talked about translocation of bacteria because of breach of the mucosa, the lungs, pneumonia, skin and soft tissue infections, especially in individuals who may have history of drug use, injection drug use. So there can be skin and soft tissue infections, which can lead to bacteremia. Next slide. Okay, so this is what the guidelines present as a treatment for pneumonia. I think we have this in the guidelines, so probably I want to talk about sepsis, so maybe we can go on to the next slide. Yeah, and then the treatment for bacteremia, this is what the guidelines recommend. But of course, for all these conditions, because it will vary, where one is not very clear, they could get in touch with experts to help in choosing the right antibiotics, including the duration of treatment. In the case that was presented, we heard of how someone was on ceftriaxone for 1 month. So that sounds quite long for any treatment. Usually you'd give that kind of treatment for infections that involve bone, osteomyelitis, and things like that. So that sounded rather long duration of treatment. Generally, treatment for most bacterial infections would be maybe 5 days, 7 days. Bacteremias would be slightly longer treatment. Let's spend the next few minutes looking at sepsis, and then we'll get back to the case. Next slide. Yeah, so sepsis, defined as a life-threatening organ dysfunction caused by host response to infection. And most of these patients will require admission to the ICU. So treatment, in summary, in case we don't get to finish the slides, in summary, treatment should include early fluid resuscitations. In some cases, if there's no response to fluids, patients may require vasopressors. And then early broad-spectrum antibiotics, depending on the source of the infection that's suspected. So you would choose the antibiotic based on the source. And then source control. So those are things that we should keep in mind for treatment of sepsis. So early fluids, sometimes vasopressors, antibiotics, and source control. Next slide. Yeah, immediately, so the things that one ought to do immediately is just assess whether the patient has shock or not. So you look for features of systemic inflammatory response syndrome, SARS. So check the blood pressure. It should be to see if it's less than 90, and then evaluate for evidence of end organ dysfunction. So someone may be confused. They may be tachypnic, tachycardic, decreased urinary output, and slow capillary refill. And then there are labs that also help in evaluation of sepsis, such as a full blood count, chemistry, if available, blood gases, blood culture, urinalysis, urine culture, and sputum evaluation, as well as culture. Next slide. And then in the early parts, after you're done with that immediate resuscitation part, you initiate IV fluids, and then you keep on reassessing for response to fluids. And then you give antibiotics as soon as possible, especially if there's septic shock. And you determine if this is a pneumonia, you think of the causes of bacterial pneumonia and choose antibiotics that will target that. If this is a UTI, you choose antibiotics that will target organisms that cause UTI. Next slide. And then for the resuscitation, you continue with IV fluids and reassess frequently. You can look at the skin temperature, capillary refill. So in someone who's in shock, they'll be cold and clammy. Capillary refill, evidence of crepitations, because if you give too much fluids, you can have pulmonary edema. Again, I didn't bring everything I wanted to share. So the studies that Dr. Mchemo and Dr. Andrews did way back a few years ago showed actually a negative outcome for following some of that goal-directed therapy, which really included fluid resuscitation and everything in the patients at UTH. And there could be several factors why that was the case. Sometimes the patients who are getting fluids are not monitored as closely to assess response to fluids. So it can go to the other extreme where you overhydrate someone, they end up getting a pulmonary edema from the fluids. And then you assess the vital signs. And then if available, serum lactate are some of the things that you can follow. And you want to ensure that the mean arterial pressure is above 65. Yeah, I think I'll end here so that we can quickly discuss in the remaining 5 minutes the questions that were posed in the case presentation.
Thank you so much, Professor Chambo. It's quite an extensive presentation, and we've seen the wide array of microorganisms that are able to manifest in HIV-infected individuals. I've seen that there are a number of microorganisms per system that can be affected. And what came out also, another thing is that something that everyone is able to do is that diagnosis should always include a history, and then we have to review the medication and the antibiotics the patient that has been exposed to. And of course, we do physical examination, and then we do the cultures, necessary cultures. If it's the GIT, we do the cultures, the particular, the stool, and we do a full septic screen in that particular individual. Thank you so much, Prof. At this moment, I think we'll allow the audience to ask the questions. I know there are 1,000 questions in the people that have in the chat box. I haven't seen the questions, but we'll still encourage that those that have questions, they just indicate raising up your hand, and then from there we'll give you the platform to share your thoughts. We also have the panel of experts, and one of them is Dr. Chitalichanda. You're welcome.
So maybe while waiting for the questions, I'm wondering if Dr. Chitalichanda can comment on the case presentation that was given, just because of the time limit. Dr. Chanda, over to you, just comments and response to some of those questions. And the questions can either be typed in the chat, or later on we can pause again to see if there are additional questions.
Good afternoon, everyone. Thank you, Dr. Chamba, for the wonderful presentation. and for the case presentation that was presented earlier. Probably we'll start maybe with one or two general comments. The case is quite very complex. I hope I'm audible.
Yes, we can hear you, Dr. Shanti.
Great. Thank you so much for the wonderful presentation. I should just say, I think Dr. Chamba has highlighted a lot of important things that we need to focus on. And I think he has also emphasized on things you should do to improve outcomes of the patients. I think he's mentioned the fluids and the antibiotics. Those are very key things that you need to think about if you want to improve the outcome of the patient. Coming to our case, probably I would just ask maybe IT could project the case. It's quite complex, but yeah, so coming to the case, probably my comments are as follows. The first things that you really want to look at is this patient in terms of who the host is. It's my usual preferred approach in as regards to the HIV status, the CD4, which Dr. Chamba mentioned we need to also focus on. And then we also need to look at other things regarding this host and risk factors for getting a particular infection or not. So as you can see, the CD4 is quite very low and puts the patient at risk of severe bacterial infection. As you can see, regarding the viral load is also significantly low. Going forward, you will see that this host has other risk factors other than HIV for bacterial infections. And probably you need to go from head to toe to look for where would be the source of a particular infection, especially you have this background of diabetes that is poorly controlled. So that also puts the patient at a particular risk. Another risk factor you can think about in terms of getting other particular infections, even including TB, would be if you come to consider the kidney injury that the patient has. So in terms of the host, besides HIV, you can see that this patient is a non-diabetic, has some kidney injury, renal dysfunction. Probably these other factors will put the patient at risk of infections. You can also go further to see that this patient had an odd stroke, which becomes a risk factor for having an infection that might be in the lungs, such as an aspiration pneumonia. So again, the source of the bacteremia might be multifactorial, but you want to look at, is it coming from the skin? Is it coming from the lungs? And the host will guide you to think about the likely source of a particular infection. You could go further and you can see that as you explore the case, you get more clues to the likely sources of infection. So you can see the decupitors ulcers there. All these have to do with the particular host that you're thinking about. So you see that there are multiple risk factors that put this patient at a risk of a bacterial infection. And then you go on to look at what syndrome this patient might have. So you have a positive culture. Again, interpretation of a blood culture is very key. How you collect the blood culture, how many you collect are quite key, especially if you collect or isolate organisms that might be found on the skin, or that might not be consistent with the bacterial infection. So it's very key you collect at least 2 blood cultures from different points. And the yield, you might have to write the time that you collect these blood cultures because it helps you to interpret. So if you get a gram negative from a blood culture, just generally, that will help you to say, we rarely get a gram negative in the blood, so that will indicate the bacteremia. But if you get a gram positive, you want to know what particular organism you're dealing with, because some organisms might not be causing the clinical syndrome your patient has. So you can see this patient has some risk factors for some organism that might be in the skin to go into the blood. Then the next thing you want to look at is what possible etiologies can you consider? So there is a bloodstream, a probable bloodstream infection, but you want to know, is it coming from the lungs? Is it coming from the skin? And then you also want to look out for other complications that might arise from that particular bacterium, especially that you've isolated organisms that might be gram-positive, like in this case. So coming back to the case, we have Coagulase negative Staphylococcus. Now, it's usually reported as a contaminant, but in some cases, it might actually cause clinical syndromes that are similar to Staph aureus. So that's why you want to get the ID of the organism to say, is it like rudinensis that can also present with syndromes that are similar with Staph aureus? Then now we go further to look at also the clinical syndrome of this patient. I've even looked at the etiology. So probably this is a bacterial infection that might be from a coagulase negative that might be probably be causing bacteremia. Now the concern was that why is this patient deteriorating? And there are again multiple factors. Usually I say if you've got a patient who is been in hospital for a long time who has deteriorated, you want to ask yourself, is it something odd or something new? So it's possible that this could be because of the infection that you have from a probable infection that you have from the Staph aureus. So you want to get repeat cultures and see what's going on. Is it a new infection that the patient might have? And again, remember that it's beyond the period that when you're more likely to get an iris, but it's still possible that you can get an iris from TB, especially a paradoxical iris. So again, deterioration of this patient might be multifactorial. So it might be, again, related to a new infection, especially the patient has been in hospital for quite a while. Is it that the patient's therapy might not be adequate for a particular infection that you're empirically covering for? And then also it might be something that's already existing, like the TB, and it's beyond the time that you're more likely to get an iris, but a few patients will still get an iris beyond that early 12-week period that the early period that we get the iris. But again, some patients with TB can also get what is called HLH, which might occur. And you could see that sometimes they'll present with anemias, they'll present with liver injury, sometimes cholesterol will go up. So they might present with complications of already existing treatments that might be there. I think that's a mouthful that I've said. I'll let Dr. Chamba also add further. Thank you.
Okay, thank you, Dr. Chanda. You've actually mentioned quite a lot, what I was going to say. Yeah, so I think just to maybe just add one or two more things. There was an important question that was asked earlier about whether repeat cultures were done, and as Dr. Chanda mentioned, with coagulase negative stuff, because it's usually contaminant, you'd want to see it repeated in multiple cultures. If it's the same organism growing in multiple cultures, then you might think that maybe it's a true infection. Then, of course, if there's a scenario where there's hardware, such as someone who's just had a CNS procedure and there's hardware in their spinal procedure, those are typical scenarios where you would get coagulase negative stuff because of the biofilm that it produces and adheres to foreign material. And then there are also organisms like Lugdunensis that you mentioned. So to say whether the current worsening conditions due to coagulase negative stuff, it's hard to tell. I think you'd want to see repeat cultures and then also assess other causes of worsening infection. This patient has been on antibiotics for a while, so it's possible that maybe the true cause of worsening condition may not be identified because of exposure to antibiotics. If at the time of blood culture, patient was on antibiotics, there may be no growth, which makes it difficult. And then, so I think in approaching how to treat this patient, we don't have time to really delve into details about each of the conditions that they have, but I think the areas of concern for me are the decubitus ulcers, source control there would be important. If there's evidence that they are very infected and they're the source of the worsening, that's an area I would focus on. And then I think there was mention of gangrene of the lower extremities. That would also be another area that needs to be addressed. Yeah, I think that's what I can say for now. Thank you. I think we are way past our time. I'm not sure. There's some hands raised. There's one from Dr. Mwanja Kakusa. I think she wants to contribute. Go ahead, Dr. Kakusa.
Thank you. That was a very interesting discussion and very ill patient, of course. I was just curious, though I may have missed it in the course of the presentation, if this patient has gone into adrenal failure and how that is being managed, and whether in the course of managing chronic hypotension, the use of inotropes could be responsible for the gangrene that is being reported. I wish I had had a chance to ask a little bit earlier, but if that is being considered in the treatment protocol, if we are using glucocorticoids, we have to be mindful not to go to supraphysiological doses, because that's one of the things maybe that us as clinicians tend to do when we're managing these patients who are very ill. Then the plan for the gangrene, I'm not sure that it was mentioned if there's a plan for surgical intervention to amputate. And also what role the inotropes would have had, maybe beyond other causes of this peripheral gangrene. Thank you.
Okay, so I'll allow Dr. Mbolo to respond to that.
Thank you for the contribution. So the patient, to start with, has not been on any inotropic support. The BPRs have been okay throughout, and they're hypertensive with enalapril, medications of enalapril and ifedipine, and it has been well controlled. So coming to the issue of the gangrene, and they advise then just that we keep monitoring and observing the patient. But now, as of this week, it has worsened. We have we've consulted them to come back and review the patient to plan for the amputation, like you have said.
Thank you for the clarification.
Thank you so much. There was just a bit of the system shut down. I hope there wasn't an echo at some point, but we are back. So there was no adrenal insufficiency in this particular individual. The BPs and the sugars have been still on the higher side as some of the parameters that we've been using to monitor. And then the presentation, it's multidisciplinary approach, like it was highlighted, and the surgeons have also been actively coming to review the patient, the endocrinologist as well as the neurologist, the physiotherapist. They're also doing physio, and also ID is part of the team that's managing this particular individual. Thank you for those questions. I've seen the time is at 13:11, and the echo session was scheduled for an hour. We are grateful to everyone that attended, and I'm sure it's been very helpful, especially that we get to see some of these patients that we've discussed. And in terms of bacterial infections in HIV, we get to see a lot of these patients, I'm sure, even in our facilities. And the approach has been highlighted to us. And also some of the guidelines, they were also quoted, the same guidelines that we are using in Zambia for the management of advanced HIV disease. So we have to make use of those. And thank you so much to the panel of experts. Dr. Chitalu, thank you for your input. And we appreciate Professor Achambwa for sparing some time to give us this knowledge. Thank you so much. I went to Dr. Mbolo, who came through to also do the case presentation, and to the IT team, Mr. Chatonda. And of course, in this conference room, there are a team of registrars. I wish the camera was able to turn so that I show you that are present, that will address this meeting. At this moment, we'll say thank you to everyone. Thank you to everyone that attended. Yeah. Okay, thank you so much. That's the audience that have graced the meeting. Thanks to the IT team for turning the camera. Yeah. Okay, so we'll close the session, and we'll leave it for registrations. If people haven't done the registration, you may still go ahead and do the registration. Otherwise, from myself and the entire team for today's echo session, my name is Mwakabaso. we say thank you so much and have a pleasant afternoon.
Thank you. Bye.
Thank you.